So today I wanted to talk about an important tool which is becoming more and more recognizable as we start working towards recognizing and treating traumatic brain injury in pediatric patients. So one of the things that I am interested in is actually juvenile traumatic brain injury. And before I start, thank you very much, Anila, for inviting me to this talk and to this forum. I am a pediatric neurosurgeon working with Baylor Scott and White and McLean Children's Hospital in Texas. And we have been working towards, so this is a community oriented hospital, which is affiliated with Texas A&M. However, there is still a lot of work to be done in the community, and that's what we are working towards. Just full disclosure, the study was actually started in West Virginia University, where I was before joining. So starting to talk about pediatric traumatic brain injury, this is a very significant issue that is faced by the population here in US. The highest estimated rates of traumatic brain injury related emergency room visits come from actually children aged from 0 to 4 years and result in 1,256 visits per 100,000 population. Adolescents are at a lower rate, which is 157 per 100,000 per year. However, the mortality is higher in the higher adolescent age than in in the younger population. It's also noted that 3,000 children under the age of 19 years die after traumatic brain injury, and 18,000 are hospitalized. There are approximately 640,000 emergency visits per year, and this is based on the CDC report from 2018. So over a couple of years back. It results in a very high cost. Now, we would imagine that the cost for moderate to severe brain injury would be significant as expected. However, what we don't realize is that despite of the mild traumatic injuries and concussions, which initially have a less upfront cost, account for nearly 81% of the $1.59 billion visit in billion costs in healthcare costs 1 year after traumatic brain injury in these pediatric patients. And the mild traumatic brain injury is actually accounted for 96% of these 319,000 patients in the study from 2015. So addressing this earlier and then trying to recognize mild traumatic brain injury and then treat it actually would result in reduction of these costs significantly. And one of the ways of doing that is trying to recognize biomarkers which can pick up the severity or the extent of traumatic brain injury earlier. Our working hypothesis was that endoplasmic reticulum stress results in changes resulting from blood-brain barrier changes actually contributes to apoptosis and changes in tau functionality. And this can result in picking up some biomarkers in patients and also behavioral differences. So our theory is that cellular stress response following an acute injury activates unfolding of these proteins in the endoplasmic reticulum and stops the protein synthesis and translation to regain cellular homeostasis. If activated for extended period, the cell will undergo irreparable damage and then result in apoptosis and proteinopathies, which are actually seen in conditions such as Alzheimer's disease, CTE, and even prion diseases. Now, this is a rough pathway. The few things that I would like to point out, which we actually looked at in our study were BIP and then later on CHOP, the capsase 12, and GSK3 beta proteins. Now, what the experiment was organized as was that we took 28 rats who were postnatal day 28. This accounts for approximately this is comparable to around 7 to 8 years uh, of pediatric patients. So we're looking at and during the first decade of life if you compare it to the human years. And what we did was on day zero, we induced a control cortical impact injury. And then over the next ensuing few hours and days, we checked for these biomarkers along the lines of the stress, endoplasmic reticulum stress pathways to see if there were any changes or not. And then also looked at some behavioral changes on day 10, 12, and 14 to assess whether or not this was affecting that as well. Finally, on day, give me one sec, sorry, day 30, we euthanized these rats and looked at the brains for tau proteins to see if we saw any changes at that level. You can see that the BIP and actin proteins, beta actin proteins, were slightly higher when compared with the sham on 48 hours or 2 days after the injury. CHOP and CHOP essentially remained fairly stable throughout. They did not show a significant difference. Then the capsaicin also remained fairly stable throughout, although 1 week after the injury, it actually did increase. However, the 48 hours did not show actually significant difference, even though it increased. Then looking at the behavioral outcomes after these injuries, 1 day after the injury, this time spent with the novel object is basically you're testing for curiosity in mice or rats, sorry, after the injury and seeing whether or not they are still curious about these novel objects or not. And you can see that the control cortical impact injury model actually spend less time with these novel objects than did the sham mice, rats. Then they did have increased impulsive behavior 7 days after the surgery, which is 1 week, injury, which is 1 week. And then 2 weeks after the injury, you can see that the spatial memory deficits also increased. So you can see that they were not recognizing their way through the maze. Now, after 30 days of the injury, when we euthanized the mice, we could see some tauopathy changes. And you can see this here, that these proteins were increased, not the PHF, but R23 and CP13, which have both been associated with Alzheimer's disease, have increased when compared with the sham, as you can see at the bottom panel. Now, what was our preclinical summary based on these experiments? It shows that the pediatric traumatic brain injury does cause an increase in the endoplasmic reticulum stress in these rats. And it led to an increase in the PGSK3 beta, but not a significant increase in apoptosis initially. There were, however, tau changes which were seen subacutely in the injury, and they actually did correlate with the behavioral decline in these rats. And as we saw in the previous slides, that it decreases the short-term memory, it increases impulsive behavior and spatial memory deficits. So our conclusions are that at the moment, we still don't have the exact pattern of biochemical changes or the entire spectrum of biochemical changes which follow a traumatic brain injury yet. However, a lot of preclinical as well as clinical studies are being done and as we can imagine are needed. The need for predictive biomarkers is essential in determining these outcomes. And in fact, recently there was a paper which came out which could recognize the onset of Alzheimer's disease by looking at a biomarker through a simple blood test, much earlier on than the symptoms actually started. Um, and then microRNAs offer a promising avenue to predict the favorable and unfavorable outcomes, resulting in possibly starting the behavioral therapies as well as treatments earlier on before these problems become irreversible. Now, what is the relevance of this to the pediatric traumatic brain injury? One paper actually looked at the microRNAs which were increased in saliva and spinal fluid following the traumatic brain injury recently in 2017. Then another study also found these to be microRNAs to be useful predictors of recovery after mild traumatic brain injury. And then also these microRNAs also help in predicting the development of post-concussive syndrome in pediatric patients. Now, what are the future directions for our study? We're hoping to look at these biomarkers in now the clinical settings. My hope is to actually look at some more non-invasive ways of identifying these biomarkers. For example, instead of using the cerebrospinal fluid, which may not be accessible in mild traumatic brain injury, trying to see whether or not these can be recognized in the urine samples. We try to see if this could be done in mice, which is a lot more challenging given trying to collect that data from mice or rats. However, we think it's a non-invasive enough modality to be, that we could potentially convince parents to actually look at. Also, saliva is another modality which has already been proven by one of the uh, researchers, which recognizes the microRNA changes. Then also predicting a scale which can predict long-term outcomes after concussion in patients. There are several scales already out there. However, correlating them with the biomarkers is going to be an additional helpful tool in managing these patients earlier on. That concludes my talk. Are there any questions?